All right. Good morning, guys. This is John Del Santos, President and CEO, JMD Healthcare Solutions, here today, early this morning, to give you this great informative webinar regarding your electronic therapy documentation and the way to success with that. We do a lot of audits with therapy documentation, both for our clients and some of accounting firms, governmental agencies, making sure that everyone's staying in line. The electronic documentation has been a really great opportunity for us in our industry, but there's also some issues with that. So today we're going to go over the keys to improving your skill through successful electronic medical records. This is going to be a great webinar. I think you guys are going to get a lot out of it. So I just want to go ahead and start moving forward with this really quick. So, just so those of you that don't know, my name is John Dos Santos, President and CEO. I have 25 years in the skilled nursing facility industry. I was a 15-year veteran as a regional vice president for the largest contract therapy company in this country. I'm an OT by discipline. I'm also a RAC certified assessment coordinator. I got an ICD-10 coding certificate. I'm on the advisory board for 2 colleges here in Indiana. I'm a fall prevention specialist, and I've overseen 40 regional managers and 2,000 skilled therapists. So, guys, overall, the reason why this is the most important, you might notice that I skipped one of those in my history here, is I'm an OIG approved auditor for both recovery audits of therapy, regulatory compliance, and MDS validation. So, with that being said, this is going to be something that's very valuable and give you guys the keys to the things that we're looking for in our audits to ensure that we're proving our skill through our therapy intervention. And as you know, CMS has made some big mandates among both these audits that are coming up with everybody. So therapy documentation is still very important, because if that's the only thing that's skilling your residents, it's the only thing they're going to be measured. So if you don't validate those therapy claims, your whole claim is gone. And that's a big zero for skilled services. So these are very important. I always think our services are very valuable, but we need to make sure we document them the right way. All right. So first of all, I'll tell you a little bit about my company. JMD Healthcare is a company that offers a multiple range of things, anything you need, from just audits of your documentation. Hey, how are you guys? What training might you need? Validate your MDS audits, or we can run your entire therapy program. Being in the industry for over 25 years, it's the bread and butter of everything I know. How to run a therapy operation and how to run a therapy program in a SNF. Help you guys do that. We'll be the management service, but you guys can actually be the provider and have your own therapist, kind of an in-house model. So in order to do that, we have to have a very specific model. We call it our RAM service, Regional Rehabilitative Assessment Management. So we're going over the therapy operations as well as the MDS operations. Okay, we have experienced managers with greater 10 years of experience. We're all professionally licensed therapists. That's a key. I saw some other companies out there. Actually, one of them, I looked at their our team, or looking at our group of this company, all assistants. I'm sorry, but there is something to be said between a therapist and assistant. The therapist can do assessments. It's really important, and it's a whole level of understanding that maybe an assistant wouldn't have been exposed to. Not anything against them, it's just what they were taught and what they learned. So making sure you have that therapist, the assessing person, the assessing discipline, is really important. We're all certified resident assessment coordinators. We all have that coding certificate. Obviously, infection control is a huge issue. They have specialized leadership training. Leadership is one thing in this industry. It's been lacking over many, many years. Success training, leadership training in the skilled nursing facilities, also a key. And they also have to pass that great exam that we put out there. So you don't get this credential just for signing up. Then we have a 5-to-1 ratio of manager to facility, which is a lot lower than most companies. We have daily virtual check-ins. We have a patient tracking software that actually monitors all your skilled patients and see where they are, finding opportunities for IPAs, increases in function, appropriate discharging, all that goes into there. We have our operational algorithm, which you can always see on our website if you're interested in that, and it breaks down exactly every piece of every operational approach we choose. We do treatment observations. We can do MDS competency checks for people who are completing your MDS. Very important. The accurate documentation is the key, as always. And we also can help you establish and develop and monitor your very own perfect restorative nursing program. See, restorative nursing programs are very essential nowadays, especially if you're going in-house. You can make sure your therapist services are skilled. Obviously, number one, they have to be skilled. But it draws a better line when your staff is properly trained on what's skilled, what's not, who can be on restorative, who shouldn't be. Sometimes you get these contract therapy companies in there, man, they want everybody on therapy forever. We know that. So they're not likely to pass them off to your restorative team. Probably could be getting it done in a better way. So just a quick idea of what we do. Don't want to waste everyone's time with this, but we offer some great services. If you're ever interested in any one of those, give us a call, 1-801-PDPMpro or www.pdpmpro.com. Someone will get back to you. We can give you a whole lowdown of kind of what we can do for you. All right? So with that being said, let's just go and get moving on. So let's go over the objectives. As most of you know, we look at our objectives by sections, so we can break this down for our training that we can use for everybody on our training platform. So the first section, we're going to about who, why, and who reviews. Why are we doing this? Who's doing this? Why are they doing it? Why do we have to be so worried about it? Where did this come from? How often do they audit? I'm going to try to answer some of those questions for you. Section 2, the current industry situation. Where are we right now in the skilled nursing industry? How many audits have been done in the last couple of years? Not a lot, by the way. Just going to give you fill that in right now. But they're coming, and they're still important. Medicare documentation requirements. Going to quickly go over some of the requirements. I mean, honestly, guys, we have many therapists, multiple regions that have therapists that are new grads over the last couple of years that have never even been through an audit yet. So there's some really specific things they're going to have to learn in order to be successful, and that's why you're on this today. Electronic documentation concerns. We all know electronics, internet, changed the world, man. I mean, it's a different world than when I was growing up in high school. But what's good and what's bad? We're going to talk about those. We're going to give you some accurate audit results. This is our information from our clients, thousands of claims actually audited, and the actual result. Every audit we do, we break down, we take that information, we put it in a big pivot table, we use that data, and we can break that down and determine where the biggest problems are and how can we address those. Actual examples of validated and unvalidated claims. I'm going to give you guys specific examples of audits that we reviewed, what was written, why that wasn't good enough, and what we did to fix it. You're going to get a kick out of that. Section 7 is going to be documentation quick tips. Quick tips, guys, just real one-liners that will help you secure your claims. Good stuff. Good stuff to remember, always good stuff to keep around, always good stuff to share. And then Section 8, the top reviewer tips about therapy claims. Now, these is a little more in depth rather than those quick tips. The quick tips are going to be things that you can just think about in a second. Oh, don't do that, do this, don't do that, do this. This is going to be some a little more in depth on some of maybe the procedural things, just giving you a little foresight here. Some of the procedural things that you're doing, which probably were put in place for a good reason, but are probably not going to be your best options now or in the near future for audits. Just little things that people like to key in on. All right, so let's go with that first section, man. Let's just move forward. Why and who reviews? All right. A report in 2009 to Congress claimed that there was a 12.1% error rate in all Medicare billing annually, representing $43.3 billion of wasted funds. Man, that's a lot of money, okay? So that came out in 2009. This is really when these RAC audits really started taking off, okay? 12% is pretty high, and that's a lot of money. So according to the same report, insufficient documentation was the largest source of improper payments, accounting for 67.3 of all errors. So it's what they wrote. It wasn't necessarily what they did or didn't do, how they did it or didn't do it. It's literally what they wrote down. 67%, man, that's a lot of it. All right. The RAC program began in 2010 and was very robust initially, with over 10 billion reclaimed in first 3 years, man. They went out with a vengeance. They went out, they were auditing tons of providers, finding tons of stuff. Well, that was a pretty intense. And there was two ways you can handle this, right? Either one, you can figure out what you can do to fix it, or two, you can complain. So, being the humans that we are, what happened was the providers complained. They thought they were being picked on. They didn't think it was fair. Came out of nowhere, which there is some legitimacy to that. I guess a little fair warning would have been better, a little opportunity to maybe double check some of your stuff and get brought up to speed. There's not a lot of guidance out there from CMS initially about how we document. Things are pretty gray areas, I always call them, out there. So they felt like it was a little unfair. I'm going to have to agree with them a little bit, but without throwing out any ways to fix it and just complaining and saying stop, I don't know about that. So what happened is they did decide to reduce it, okay, to a certain percentage, okay? So it went from 2%, which isn't even that big of a number to me, 2% of all claims, to 0.5% claim on a 45-day cycle. So they went back 45 days. So 0.5%, think about that, guys. 0.5% of all of our claims were getting reviewed, okay? That's a very small percentage, which means most people, I would have to say, probably watching this right now, have not really been part of an intense audit yet. A big deep dive probe audit, full payment review audit, probably not a lot. People, that's why when we go to these buildings and I bring up things that people shouldn't be doing, they're like, well, we've been doing this for years. They're not lying. That's true. You probably were doing this for years. Unfortunately, you've just been doing it wrong for all those years. So the important thing is we must remember that not many of our claims have ever getting reviewed or not getting reviewed. But when they come, they are going to find stuff. And the more they find, the more they're going to start picking on you. So the best thing you can do is be prepared before they get there. We should always be documenting like someone's going to be reviewing it. Chances are someone will be. It may not be a Medicare or a MAC. It might be a compliance officer, maybe a third-party auditor, something like that. But always write with the thought that someone will be reviewing this for payment someday. And you'll be a little off better. That's your first tip, I guess. All right. So we did the why. Who's the who? Who does this? So the recovery audit contractors, RAC contractors, okay? And their job is to detect and correct past improper payments to prevent future improper payments, okay? Now, usually this is an RN because they're usually looking at the entire claim. When we're talking about these Med A claims or Part B, it's probably more on the Med A side. Part B is going to be more of a therapy-driven claim. But still, on the Part A side, usually an RN, just because they have a more of a big round understanding, top to bottom, admissions, medications, diets, weights, all procedures, nursing skill and procedures, then add in some therapy. But usually, initially, that RN is going to be the first person who's going to review this claim and kind of decide, is this yay or nay, and should it have to go to the next level, all right? Now, CMS has assigned those contracted MAC groups that we always talk about are MACs. They usually cover multiple, 2, 3, 4 states at a time, and they get this contract through CMS, and CFS uses them to monitor their claims, kind of farming it off, which is not a bad idea. Using a resource to get a problem fixed, and it's been working out thus far. But they help oversee this and help oversee those payments. So it's that MAC group. You ever hear the MAC? That's who they're talking about. Okay. Usually, our MACs are going to determine outliers based on the use of CPT codes, which are billing codes, the excessive case mix utilization, or rapid changes in billing. So, when we talk about excessive case mix utilization, so if we have certain payer, like special care high, extensive services, billing more and more days, and they usually determine this based upon the people around you, your peers, based upon the other facilities right around you. So the audits are triggered by outliers in billing utilization of certain CPT codes or PPS days in a specific geographic area. All right. So are they billing more codes than everyone else? Are they billing more days than everyone else? Are they billing higher rates than everyone else? If they are, let's check them out and make sure that they're legit. And if you are, great. If you have everything in place, no problem. Don't have anything to worry about. But like we just talked about earlier, 67% of those have improper documentation. They didn't say improper treatment. They didn't say improper procedure even. Therapy documentation, period. They look back, what they read isn't skilled or isn't skilled enough. All right? If reviewed and determined payment was not warranted, you will have multiple levels of appeal up to the ALJ, which is the administrative law judge. So there are ways to appeal these, but I can tell you guys this. The best way to survive this is not even get in it. Clear it on your first review. That's your best case scenario. There's a lot of time frames you're talking about, a lot of materials, dates you're going to have to keep track of. Could be virtual or phone, could be in front of a judge, but it takes and the matter of time. Okay, so you're talking about possibly could take up to a year to get your claim completely reviewed and paid. A lot of providers don't have a lot of options to wait years for payment. They need it now. Okay, so just remember there is that appeal process, but you're better off catching that on the front end rather than the back end. A lot of more resources, a lot more time. Cash flow is an issue with facilities, so if you really want to be up to speed on your cash flow, you got to make sure all your claims you're sending in are going to be paid. Okay? All right, so that's the who. Now, let's go over the current industry situation. This is section 2, moving into section 2. Current industry situation, right? CMS conducted very few interviews since the start of the COVID-19 pandemic. That's 3 years, man. That's a long time to not be getting reviewed. Okay? So, like I said, many people started this industry before 3 years ago. So, very few have been done. I mean, hardly any in my regions. Now, the most recent, they call it the Comprehensive Error Rate Testing Program. This is a comprehensive audit review that CMS does with conjunction with some third-party auditing firms. They discovered that they were looking at a projected improper payment rate of 15.1% in 2022, up from 17.79 in 2021. That's double what it was. All right? That's a big number. Okay? Remember when we talked about 2009? They were worried about the 12%. Now it's up to 15, and guess what? It's more dollars overall, right? I mean, usually everything's going up as the years go by. 2009 to 2021, probably pretty significant bump up there. So big numbers, big dollars. Medicare saw this and they said, we're going to have to take a look at stuff. So CMS is implementing a 5-claim prepayment probe with widespread provider education to each MAC for every SNF in their jurisdiction. So every provider is going to get this, guys. 5 prepayment claim reviews. And if you don't pass, well, you obviously won't be getting paid, because if you didn't pass it, you wouldn't deserve it. But you can also rest assured they're going to want to do some training with you, talk about a few things, and they're probably going to end up coming back and double checking it. Okay. Now, they're kind of doing this so they don't get into the same mess before, where they all of a sudden were popped out there. They're doing all these audits and people are getting these denials. And what's going on, man? You never even showed us how to do this the right way. Well, they are going to be doing training with these. They are going to be doing some follow-up, either of your virtual or some kind of online resource, or if you're over a certain percentage, they're probably going to be setting something up with you either live or virtually live, right? And kind of going over these with you with a little more detail, which I think is a good thing. Now, this implementation date started June 5th. So this is already up and going, man. We're already into August. So up and going, and I have known a couple of people who have gotten these. They're pretty straightforward audits, but they are pretty comprehensive, and they are prepayment, and they are showing up. So this is a real thing. Okay. Now, the 2 causes for overpayment, okay, was number 1, case mix, your CMG. This is PDPM, right? The CMG components put together give you your rate. The CMG component documentation was missing, okay, and 2, a HIPS level change based on the documentation was insufficient. So when we're talking about that doesn't necessarily mean IPAs, because historically we don't do a lot of IPAs. You should be doing more, by the way, and that's a whole other webinar. But not necessarily IPAs, but say your patients that were long-term care, go to the hospital, right? They have a 2 nights, 3 stay, come back skilled. All of a sudden, their HIPS is drastically different. Why is there so much? Why have so many things change over one hospital stay? Either your MDS wasn't coded correctly in the first place, or it's encoded incorrectly now. Either way, let's take a look. So those changes is what's going to trigger. And trust me, guys, you want to identify change. That is the purpose of MDSs. We are monitoring our residents, accurately capturing where they are functionally, medically, service-wise, all those good things. And we should be finding change when we do this. But your change has to be supported. And that's what we're going to be talking about here today. And there's other webinars in the future when we talk about MDS audits that would be helpful for you guys too. But this was more geared towards the therapy side first. Still, same regard. The documentation submitted must be sufficient to justify the changes. Okay? Therapy claims need to be validated to maintain Medicare Part A coverage if not skilled by nursing. Remember, when PDPM first came, a lot of people were saying, well, therapy is not important anymore. We don't need to get so many days or so many minutes. That's very true. It isn't dependent on our days and minutes, and I think that's a good thing. I think that's appropriate. But what you do need to remember is that it's still dependent on your patient's need of skilled level of service. All right? So when we look at the examples, this will make more sense in a few minutes here. If we have documentation that we submit that is insufficient to support the skilled services that we're delivering to our residents, that claim may be considered not validated, which means that claim for your resident for that Medicare benefit stay may not be covered. Because if there's nothing else to cover them for nursing, okay, therapy's it. And if they determine that wasn't warranted, guess what? No pay. Not going to work. You must have a skilled service. Everyone knows that. And you must prove it. Okay? So this therapy documentation, man, still very important. Because if this doesn't get validated, there's no backup. They're off skilled. All right. So looking now, we're going to go ahead and move into Section 3. All right? So Section 3 is Medicare documentation requirements. Okay? Now, what does Medicare actually require us to be doing, with our patients as far as documentation goes? All right. The first thing I want everyone to remember is that therapy plans must be established, monitored, and maintained by a qualified clinician. Your clinicians are PT, OT, and speech. Right. That's why I was a little surprised when I had the management company starting this new business, just 1 or 2 years old, and everyone on there was assistant. Well, who's monitoring and maintaining and establishing the plans and reviewing them for you guys if you're all assistants? It's a little weird, but that clinician is still very, very more important piece. Your assistants need to be supervised and should be supervised. That is a requirement. Does it require direct supervision? No, not over your shoulder on site, but that claim is always to be monitored by the therapist, right? And there's going to be some specific things that you're going to have to do to prove that. Services that are delivered are at a skilled level of care, supported by a medical record that indicates a clinician's unique professional contribution. All right? Unique. I want you to key in on that word. I'm going to tell you why. The biggest problem with our documentation right now is it's not unique. It is very general. It is not specific to usually the patients that you're treating, because people forget to put the specifics in there. They put a lot of the word builds. They put a lot of the decreased functional ability, decreased range of motion, decreased safety awareness, increased risk of falls. Yeah, we know that. Most of the residents we work with have all those things. Just putting those is not going to be enough. It's not enough, guys. And I'll get more into this in a few minutes when I start breaking down some examples. But we use those same words with every one of our patients. It's not going to be enough. It's not going to improve your skill. That is not unique, right? That is a very generalized way of documenting. And sometimes this electronic documentation leads us to do that. And you want to break that habit. And we're going to show you how to do that. The medical record must clearly describe the patient's conditions before, during, and after therapy intervention to support the patient significantly benefited from ongoing therapy services, and that the progress was sustainable and of practical value. Like that, it just makes sense. If you're only going to get a little bit of progress and be in a SNF for 100 days, they're not going to pay for that. It's not enough. You got to make a lot of progress to be there that long. But the most important thing in this is you must clearly be able to identify what happened before, what was happening during, and what was happening when they leave, or how they benefited overall. That would be more of the discharge information, and how you contributed to that. What was your contribution? Another thing with the documentation we're seeing, hey, it's a great story about your residents, very little about therapists. Be sure to put what your therapists are doing. What is their skill? Where do they contribute? What did they do? Don't just write a book about what the therapist did. We don't need clinicians just following patients around and tracking everything they've done through the whole day and how many exercises they did, how many reps, how much. What did the therapist do? What did you guys do to contribute to that progress? Okay. Services were reasonable and necessary based on the most current industry standards and the most recent evidence-based research. So you want to make sure what you're doing is known by our medical practice, our medical boards, as being, a sufficient and good skilled delivery service, and it's going to make progress. That's why we use our CEUs, right? That's why you guys kind of do this. That's why you do other CEUs on shoulders and falls and things like that. We want to keep up to speed. They're doing research all the time. We want the newest and greatest form of treatment because two things will happen. Number one, our patients get better on a more consistent basis when we're using things that have been shown to work. Number two, it makes you clinically efficient in what you're doing. If we're doing the exercises that aren't going to benefit them the most, why are we doing them? We want to be efficient in what we're doing. We want to make sure we're efficiently restoring our patients' abilities, not overtaking extended periods of time to get to our results. We want efficient plans, efficient delivery, and efficient results, improving our skill. And that's the best way we can do it, right? All right. So on the next section here, going over to section 4, which is electronic documentation concerns. So what are the concerns? Why do people think about, as a reviewer, they have electronic documentation, like most people do now, but they use that system. Oh boy, what are they thinking about in their head already? Let's go over a couple of these. Now, the biggest concern is most places are moving to this. Most places are doing the electronic documentation. So we're losing some of the great examples we used to have from some of our other buildings that were still writing those narrative notes, because narrative are the ones that tend to be the most supportive. But we're losing those examples rapidly because most people are moving over to this. So that is a concern, Therapy, electronic medical records is designed for more efficiency rather than supportive content or regulatory needs. That's just the truth, guys. I'm sorry. If you read through these, yes, it's efficient to go through and make checkoffs. It's efficient to use these word builds and drop those words right in and then just fill in around them. I get it. Efficiency, it means something. I'm not saying it doesn't mean anything. It does. It's important. But you need to make sure that what you're doing is going to be supportive to your skill. All right? So we have to make sure that we're being efficient, but what we're writing is going to get the claim paid. I mean, who cares if you're really efficient if you just got $0 for what you just did? It's not going to matter. It's actually, they're both very important. So you think about that when you're going through. If it seems easy and fast, it might be too easy and too fast. It should be a little bit of work to do this. Documentation should be very specific, and you should have to think about it. You should have to think about what you're writing. The customization of EMR has led to non-specific, repetitious, and generalized statements that do not support medical necessity or skills of a therapist. That's the truth. We're seeing it across the board. It has led to that. I'm not saying it's the EMR's developer's fault, because therapists should know what the requirements are and what they should be putting in there. It's just that they're not. They need to be reminded. Okay. Push a less narrative emphasis and increase focus on the drop down and the checkboxes. Remember, this is the concerns. The concern was that it's push less narrative. Oh, that narrative takes way too long, way too much thinking involved there, way too much time. Just we'll put some checkboxes in there. Well, I'll be all done. Slow down. Make sure you put enough in there to support it, because you can't do something sometimes with just a check or a drop down. It leaves a little more effort. Increased confusion with section GG scoring due to the changing of traditional therapy levels of function to nursing MDS levels. Some of the software vendors have actually changed their level of function, their therapy documentation, to match the MDS. And I know why they're doing it. Again, almost everything we do is for a good reason. They did this initially for sure to make sure that people weren't confused about these two levels of function and how they interact and how they relate to each other. But what I'm saying is, therapy is its own skill. It is its own service. All right? So if they have to do it their way, let them do it their way. There is a way to cross-reference these, but the problem is we don't have people to do that. And that's what one of my things that my company has kind of tried to develop, bridging that gap between therapy and MDS. And we've done a really, really good job with that. Personally, I don't think you should change your levels of function in your therapy documentation to match sex and GG. I think you should be keeping them as the therapy, the ones we learned in school. Those are how we learned it. That is how we do it. We have a different agenda. That's the way it should stay. We should be able to have staff and professionals that can do the crossover, the crosswalk with those two levels of function without changing your therapist's way of doing things. That's just my opinion, but it's doable. I think changing it to match is kind of an easy way out, a way to not have to learn and not have to understand it. Again, my opinion. All right, so next section. Let's look at section 5 and go over some actual results data. This is from our audits, thousands of audits we've done with our clients from July of 2021 to May of 2023. Those were the time frames. And there were over 1,500 claims. And these are the actual items that triggered the most. We have 86 trigger points. We use the same audits that we do with our OIG accounting firm clients when we do our audit reviews for them as we do our regular clients. Just our customers. So you're getting a governmental audit that's been passed all the way up to the top of the food chain and reviewed on a regular basis to secure your claims. It's a great deal. These are really, really comprehensive. OIG really enjoyed using them. We have graphs and trends and all kinds of stuff you'll see. But these are the actual results of the top items. So every trigger point we log and we get a percentage rate of how often it's coming up. 44% of our claims, the specific exercises, progressions, patient's tolerance, and therapist skill is lacking. Those are the things that are required. 44% of what we review are lacking in these. All right. And then those are the actual regulations for the skills of a therapist under the regulations, publication 100.2, which is the Medicare Benefit Manual, chapter 15. And then we have also another section in there, section 220, as well as just a couple different lines they're in the same chapter, they're in the same section, but a couple different areas where we have they address these. So we always try to put that in our audits and our results. We want to make sure your therapists understand where they can look for a reference. Okay, and sometimes I'm telling you right now, when we do our audits, we'll send a link to the benefit manual. Sometimes just reading that little section will give them the hints they need to do it the right way. Some of them have never seen this. I was in contract therapy for how many years? They didn't even show me the benefit manual. I mean, we didn't even talk about it. So I'm not sure why, but we never did. This is where the rules are, guys. This is how we learn how to do our stuff. All your therapists should be looking at these on a regular basis. I mean, it's almost essential they have to, especially nowadays when these audits are coming. But that was the main one, our therapist skill. Okay, scary, right? Because that's what they're looking for. But 44%, almost half, 39%. Okay, plans for continuing education, specific and individualized. I mean, you could probably even skip that first part. It's the specific and individualization of everything that causes you to kind of go the wrong way with these. But that just so happens to be that one trigger point that happened the most, 39% for the continuing treatment. When we're talking about continuing our skill, maybe a progress note, going over, or a recertification, going over to the next month. Why are we continuing? Why does a therapist have to be involved to do it? That's what that's referencing to. And that's very, very important. Again, very, very skilled what we do. Look at this one. 37% appropriate PTA, OTA supervision is documented. It is a requirement that your assistants are supervised. All right. Now, for us auditors, we are to assume the supervision is being done. The problem will come up when something happens where we no longer can assume that. All right. And I'm going to give you a really big hint right now. This is most prevalent and the biggest issue when you have claims of patients that are not progressing. Right. It's hard to deny a claim for someone who got better, went home, and was a success story. Okay. It's a lot easier for me to deny a claim when they didn't get better, they didn't go home, they didn't have that successful ending. Now I'm trying to determine why didn't these services work, And were we not doing certain operational things that probably could have got that patient better if they would have done it in a different way? That's what I'm looking for. And that's what's going to get your claim denied. The easiest way to get your claim paid for, obviously, is get results. People get better, go home, everyone's happy. But that isn't the only way, all right? You have to prove your skill, prove that's individualized, because not everyone you treat is going to get better. I'm just going to have to tell you that. No one told you that before. Sorry to break you the bad news. Not everyone you work with is going to be better and is going to reach all your goals. What do we do to continue to prove our skill when we're not making that progress? People have a hard time doing that. And one of the ways we do that is proving especially if you have a lot of assistants treating, you got to make sure that you're documenting that there's conversation happening. Because one of my questions would be, I see no supervision logged anywhere with your assistants, okay? Your patient's not progressing. I don't see goals updated. I don't see any of the treatment plan modified, okay? Was your therapist communicating with your assistants enough to make appropriate modifications to your plan to ensure the success of your patient's recovery? How do you prove that? If you didn't write any of this stuff down, you can't. So I'm going to have to assume that maybe it didn't happen, and that's why one of the contributing factors of not progressing, which is true. We should be updating our plans. If we're not making the results we need to try something different, okay? And as you know, the assistants cannot make modifications to the plan. Only the therapist can do that, okay? In order to do that, you must be giving appropriate supervision. The next one, 31% CPT codes considered acceptable medical standards for the patient's medical condition. This you run into when people use the same codes over and over. They put ADLs or therapeutic exercise, 97110 every single day, 60 minutes. See, you gotta use a range of codes, make sure it contributes. That's why we have to do that daily encounter note. That daily encounter note, we're supposed to be looking at that code and putting exactly what we did that would fall under that code. You don't necessarily have to prove medical necessity or improving, not improving, but what did we do, therapists, not what did the patient do, what do we do as therapists, okay, to build that code? What was it contribute and what was the skill? That's what that encounter note's for. It's actually just support your coding, not necessarily give a update on the patient every day. It's to prove that those billable codes that you used were appropriate. People have a hard time doing that. And, I'm just going to say this really quickly. One of the reasons they have a hard time doing that is because a lot of maybe the therapy company or provider, they limit your therapist so much on what codes they can use. They get like 2 options, so big deal. We'll just keep going back and forth. The more choices you give your therapist to make, the more skill they'll put into making those choices. You lower the amount of choices they have, now it just becomes, well, what else am I supposed to do? This or this, I guess. They don't even think about it. Give them choices. They'll pick the right one. Let them think it out. They're all therapists. They all went to school. Let them figure it out. And hey, if they make a mistake, oh well, that's their mistake. They'll learn from it. But give them the choices to do it. That's my philosophy. Anyway, 30%, that last one here, on the treatment plan, frequency duration, specific and reasonable to meet the patient's needs and achieve the goals. Your responsibility, and if you look up one of those regulations, I don't remember which one it is there, of Chapter 15 or Chapter 8, but it says, we are to make and develop treatment plans that are the most efficient way possible. So efficient and effective actually are the 2 words they use. So what does the efficiency have to do with it? Is it 5 times a week? Is it 2 times a week? Is it 1 time a week? What is the most efficient way to get our patients better and the most effective way through the interventions that we're using? Those are the 2 requirements when we make these treatment plans, okay? Don't ever forget that. Your frequency is important, and it needs to be followed, and it shouldn't be a range, by the way. I hate that. To me, a frequency range of 3 to 7 days a week, that's not a plan. That's a guess, and that's a cookie cutter way of writing it. If you need to modify your plan, let me give you a scenario. So say you pick up Mrs. Jones, right? Pick her up 5 days a week because you want her to get better. You're there every day, and so is she. She's in there for a deconditioning condition where she went to the hospital with a UTI, laid in bed for a couple days, almost all day, all night, having a real hard time walking, maybe fell walking to the bathroom one night because she feels so weak. Deconditioned, weakness, muscle memory, ADL training, dynamic balance, all those things that are really important to get a patient up on their feet again. doing it 5 times a week because you know this is critical. You have to be able to do this every day or they're not going to get better fast enough. So it should be 5 times a week. Hey, if it doesn't work, it doesn't work. Then maybe 2 weeks in, you can call for me and say, hey, man, I want to call an IDT meeting. I'm working with Mrs. Jones. We're not getting anywhere. She's having a real hard time participating every day. I might want to go in and talk about how I'm treating her. You guys take your therapist in there. You have the discussion. I'm going to try her at 3 times a week. She's just not wanting to do it every day. She's getting her very agitated. She's making her stay in bed longer because she's thinking about she might have to go to therapy if she gets up. She doesn't want to get up. Something could happen. Or maybe she says she's really tired. She's so tired, man. She can't even get up. She can't even get up and do it. She's laid up in bed till 3 o'clock in the afternoon. Something's going on. Doctor may say, hey, you know what? I give her something at night. She has trouble sleeping. It can have some lingering effects. Let me try something different. So he tries a different medication. Next thing you know, she's doing better. See, if you don't sit down and have discussions about these things, those changes don't happen. So if you just would have put 3 to 5 days a week and you're just picking and choosing and everyone's going on their merry way and you'll do 3, you'll do 5, then maybe try to do 3, maybe you'll get 1. No one even talks about it because it's within the range. Then all of a sudden you have your therapist putting in a notice for discharge because she's not getting anywhere. We haven't even had a meeting about it yet, right? Everything that's going on with that resident should be discussed. So if you're going to make a frequency change, guys, you make it after. You can't use these ranges anymore. I know what they're intended for. I don't even want to get into that. It doesn't matter. The important thing is, if you want to properly get results with your residents, you need a specific plan, and this is what they're paying you to do, by the way, a specific plan developed by a therapist to do that. If it doesn't work, you have a sit-down communication with the rest of your IDT team, and you make appropriate changes with everybody involved. That's the way it should be happening, and that's the way it should be done. Many times it doesn't. And I'm not saying everybody does. People do things right and wrong all the time. It's a procedural thing that just needs to be discussed more. No ill intent here. People aren't trying to get out of having these conversations. They just got out of practice with them. So get back into practice of having more conversations, clinical conversations, and making sure everything's accurate in that documentation, and take credit for those. If you do have a discussion about frequency and you end up changing it, note that. That proves involvement. That proves your skill. Okay? It's the skills of a therapist that will have to determine what the new appropriate frequency should be and why, right? If I say a patient's not progressing, but we're doing these things, I'm okay with that. I'm okay with someone putting in the effort to reestablish their plan to get progress. Now, if you don't say anything and you just say, well, I'm getting rid of her, not get anywhere. No changes in goals, no what. See, now I have a different feeling now. Now I'm going to start asking, see, you're using a frequency range. What was your plan? Why didn't you try 5 and go to 3? Now I'm going to get all over you about that. And if you were saying it, well, actually it's not about that at all. My manager told me I have to do it that way. See, now we're going down a bad road, guys. We shouldn't be doing things just because the manager told me to do it that way. Everything we're doing should be for your patients and for their quick, most efficient and effective recovery, not because your boss told you to. Not there's nothing to be said about doing what your boss tells you to. I'm not saying that. I'm saying you guys need a new operational approach. It is good for someone to be in charge of making sure things being done right and held accountable and hold themselves accountable. I'm not saying that's a problem. The problem is the approach should have been different, not the oversight. Okay? So those are actual results from our claims. When we got there, 1, 2, 3, 4. The top 5. Probably top 5 concerns that we have in the actual audits that we review. All right. So let's go into the next section, section 6. Okay. Now this is where the magic happens, right? Because I hear people all the time, oh, John, you're really good at telling me everything I do wrong, but you're not, you never help me do it right. I'm like, okay, well, fine. We'll do that today then. Fine. Here are some really good actual examples. These are from our audits. Got permission from therapists to use these. I'm obviously not putting names of anything or anyone in here, but I didn't want someone to see this and say, oh, I wrote that. No. But all approved, all okay, all used for good for us to look at these, maybe discuss them a little bit, and maybe the next ones are a little bit better. Okay? So, first one, number 1 example of this is the unvalidated claim when we first looked at it. And the source of this was off a PTDC summary. The summary of skilled services and this is probably, I think Net Health is what it looks like, but we have only a few different vendors we use. The interventions provided, listen to this. I mean, seriously listen to this. So just let me know. These are real, by the way, not faking them up, not trying to make some extravagant, improved things. These are true examples. And the way I do it with my guys is I will review them. I cut it and paste it just like this. I rewrite it right underneath, send it right back and say, this is what I would have wrote. Best way to learn it, best way to do it. I get a lot of practice doing it that way, and I see a lot of scenarios. It's what everyone kind of should be doing for themselves as well. So anyway, interventions provided. Therapeutic exercises in order to attempt to increase. I mean, this is your summary of skilled services. I would be pretty direct and objective in what I'm saying. I wouldn't be attempting a lot of stuff in my summaries of what actually happened. That would be more of my plan. But anyway, just think about some of the words we're using here. In order to attempt to increase lower extremity range of motion and strength to facilitate completion of functional mobility with less assistance. Okay. Therapeutic activities in order to facilitate completion of position changes with improved quality of movement. Okay. Gait training in order to attempt to improve stepping strategies with various adaptive equipment in order to improve ambulation within the environment. Okay. Sounds really nice. But I can tell you this. I read this, the same words, in the same order, probably 4 or 5 times in a row for different patients. Okay. See, nothing specific. I mean, all of this is very general. Lower extremity range of motion and strength to facilitate functional mobility. Yes, most of our patients are trying to do that. Therapeutic activities in order to facilitate completion of position changes. Most of our patients are doing that. Improve quality of movement, gait training in order to improve stepping strategy. Most people. Again, adaptive equipment. Come on, guys. This could be applied to everybody. I mean, really. It sounds nice because it's hitting the main points. It's not specific enough to be in the summary of skilled services for individual claim. I mean, this could be the summary of skilled services for all your claims. Okay? So what I did is I went ahead and I kind of rewrote this for them. I said, guys, looking at your rest of your evals, looking at your plans, this is kind of how I would have done this. Therapeutic activities to facilitate functional mobility with PT, providing both verbal and physical cues to correct anterior translation of femur while moving in and out of squatting, thus promoting appropriate body mechanics from sit to stand. See? Specific. I'm saying exactly what my PT did. Okay? I'm saying exactly what the treatment was, including muscle groups and interventions of where we're putting our hands and what we're kind of working on, and the actual specific movements our patient was doing that promoted the increased functional ability, that sit to stand ability, right? That's specific, all right? And here's the next piece. Gait training facilitated by PT, again, clarifying what my PT did, with increased weight shift, allowing patient to slow cadence and focus on appropriate heel strike, all while coordinating reciprocal arm swing, resulting in reduced agitation, initial steps, and preventing tripping over feet. See? Very specific. Is that gait training in order to attempt to improve stepping strategies? Yes, it is. But that is specific to this case and this patient and their needs. And what your therapist did, increasing the weight shift, slowing the cadence, making them focus on heel strike, and coordinating that reciprocal arm swing. That's skilled. That's skilled. Okay? Sounds much, much different, doesn't it? That validated one, that's a no-brainer, man. That's paid for. That's skilled. That's therapy right there. That first one, without seeing the rest, I can't tell you it's going to be a denial. And listen, guys, none of this stuff is a reason to deny right off the bat. I'm not saying whoever wrote that's, they're not paying. Looking at your entire claim, that may not be enough to prove what you did. If you made no progress, didn't get anywhere, they didn't walk anymore, say their goal, you didn't reach the goals, you didn't improve on the goals, that would have to be in question. Okay? All right. Well, I noticed you didn't reach your goals. What exactly did you do then? What were you working on? Not specific enough, guys. This one, much more specific, definitely could. Okay? And listen, let me tell you this too. I wrote that. This shows how not hard this is. I'm an OT. I'm not even a PT. Okay? And I still wrote that, right? Because I read it in the eval. I'm a clinician and I know how to assess, and I saw the improvement and I saw what the therapist did, and that's how I wrote that. I didn't have to go to PT school to figure out how to do that. You know, I have enough of my knowledge base to use what I saw the therapist do. So what I'm saying is, anybody can do this, man. You don't have to be some rock star note writer. I'm not a rock star note writer, by the way. You can ask anybody. I was never the best at notes. But I do follow the rules, okay? And I do remember them, and I'm diligent in making sure that they're followed. That's why I get good at this. And practice. That's it. Practice. Practice writing like this, you'll always write like this. It becomes the way you write. You write like the unvalidated one, you'll always write like that. And you're going to get a lot of denials. All right. So let's go to our second example. Unvalidated. Our source, outpatient PT DC summary. Okay. Here's the interventions. Patient seen for manual therapy, strengthening, balance trading, and simulated activity in mounting a horse. Okay, guys, I mean, yes, those are interventions. Those are not specific enough to do a summary for what you do with your resident. Way too general, all right? Summary to progress response to treatment. Patient had very good overall progress. Thank you. And I'm not trying to make fun of people or anything. I know people get in habits like this, but you need to think about who you are and why they are reading this. They are reading this because you are the professional. You are a skilled professional that's going to give great insight to why a patient did or didn't progress and why these services should be paid for. That isn't enough to prove that. I mean, you even know that by reading that. That's just not enough, okay? Patient gained very good overall progress. She started last August with pain, unable to drive, unable to ride her horse, and very low activity tolerance. She is now able to ride her horse, drive her truck, no pain, started looking for a job. That's great. I mean, that's great that you got those outcomes. And I'm not saying that this wouldn't be paid for just for that reason. Again, it's very hard to deny the claim when someone's gotten better and gone home. I think that's a great job. But if you ever wanted to get really specific and say, well, did she just spontaneously improve, or was therapy involved in this? Because there's nothing in here about what a therapist did at all with this person. Are you just watching them and said, oh, yeah, I'm just monitoring, see how you're doing. Come on here, do your stuff. I'll just write down what you did. You guys got to put a little more stuff, a little more information about yourself and what you did. All right. So let's look at how we write the intervention. Patient has increased muscle guarding and stability to right-sided lumbar paraspinal musculature, increasing hip stability in standing due to increased strength of the proximal hip muscles. Okay. Standing dynamic balance exercise has increased range of motion with no signs or symptoms of pain with functional activities such as squatting or lifting of one leg with controlled and appropriate weight shift. All right. Therapists also utilize GHC inferior glide to decrease, the glomerulohumeral joint, that shoulder joint, basically. Use these words, man. I'm telling you. Now you sound like a professional. Okay, when you start using these very specific clinical words, that's what they're kind of looking for. I mean, we can say shoulder all day. It sounds a little bit better when you do it this. Not that it doesn't change anything, but at least we're writing, something in here that's specific about this patient. Look at that first one. I don't even know what was wrong with this person. Was it her hip? Was it her shoulder? I don't even have enough information to know what's wrong with the person at all, what you're even working on. So putting that little tidbit about what the specific area is, very important, okay? Inferior glide to decrease pain and reduce muscle guarding, further increasing strength and stability. It's awesome, man. Sounds really good. Progress. Following therapist-guided standing activities, strengthening exercises, and joint mobilization, the patient demonstrated improved ability to move through the existing range on all planes without increased pain or loss of balance, enabling her to drive her car, return to work, and increase her quality of life through age-appropriate social activities. Now, I put that part on the end there because if you did notice, balance training, and simulated activity of mounting a horse. I don't remember if she was a horse trainer, if that was her job or anything, but I will mention this. Be very careful when you're treating patients and trying to increase their ability to do leisure activities. Medicare doesn't like to pay for that, okay? You must link it to quality of life, okay? They don't want to pay for things that aren't functional, or they're not occupational. If they're an outpatient, they're not things for their job, or they're not functional. They don't like to pay for just stuff they like to do. To have Medicare pay for that with their Medicare benefits. You ought to make sure you are making it an appropriate suggestion that this is for improved quality of life. You're making age appropriate social activities, okay, stuff like that. Be sure that you're just not saying, well, these are leisure activities she likes to do now and then, and she wanted to get therapy to get those better. They're not going to be really excited about that. Just a little hint. All right, let's keep moving here. Now, I threw this one in the last second. I was putting my thing together, and I came across this one. I'm like, oh, man, I already have all my examples. I'm like, I'll make it a 2.1. Example number 2.1, because it's from the same claim, I think. I don't remember. The unvalidated version, outpatient patient DC summary, prognosis. Prognosis to maintain current status, excellent. Patient is aware of prognosis and diagnosis, yes. Recommendations, continue home exercise program, HEP, and all activities she was able to accomplish. Come on, man. You guys, please. You got to be a little more specific in what you're right. Excellent. Yeah. You know how many times I saw excellent yes? Excellent yes on every one of these things. All right. Now, for outpatient therapy discharges, you guys know there's some different additional requirements. You have to give the prognosis, and you have to show that the patient understood it. And there's other things, a few other, have to kind of cover that in your discharge summary. Okay. So be specific with those things. This is just too general. All right. So let's validate that prognosis statement really quick. Patient has excellent potential to meet expected outcomes from therapy due to the excellent motivation to return to work, young age, no prior injury to right shoulder. Other contributing factors are her overall good health and physical conditioning prior to injury. Expected to be successful and safely return to full duty post-TC. Patient agrees with the prognosis and has demonstrated 100% of their ability to complete the home exercise post-TC to prevent another decline in functional abilities. So when you give your prognosis statement, just to say it's excellent, it's not enough. Why is it excellent? Why would you say that? Why do you think that? Well, because she's in great health. She hasn't any other thing. She's young, all the things I wrote. You knew these things. These aren't even therapy things. It's just things about your normal observations. Make sure you note those and take credit for those. All right? Because just saying excellent is easy. And if I ask someone a couple of times, okay, I have excellent for this, or this person. Tell me each one of those specifically. Why those are all excellent. Probably couldn't do it. People just put excellent because they think that's what you're supposed to put. Prognosis to maintain current status, bad. Impossible. Of course, that doesn't sound good. You just got a whole bunch of therapy someone just paid for, or Medicare. Actually, patients paid for it, but Medicare just pays for this out of the patient's funds. Okay, and you're going to put that the prognosis is bad? I mean, no, of course not. That doesn't sound good. But if you are going to put excellent, back it up, man. It's so easy to put that and not put any backup. You got to prove it. You got to prove what you're saying. Okay, so that's a good example on how to do that. I just want to throw that in there because that's a hard thing for people to grasp when you talk about these DCs of outpatient therapy patients, and you have to have that prognosis statement. That is to make sure, and the ability to continue and demonstrate their home exercise program, you are supposed to put a specific number, 75%, 90%, 100%. Be very specific in what you're doing, and you're only strengthening your claims. It's not hard to put 100% if you know they can do all their exercises. Just put 100% in there. Get used to being more objective in how you write. It's got to be very clear to the reviewer that you are confident in what you wrote and what you did and your statements of when the patient is leaving. And if you don't write very specific, objective information in the content of your notes, it's not perceived as being confident in your writing, okay? If I write 100%, man, that is saying something, man. That's telling someone they can do all of them. I watched them. They demonstrated it to me. I'm confident they can do these at home, okay? They want to feel that confidence. Make sure you give them that. All right, next one. Example 3, unvalidated. The source, again, an outpatient PT evaluation. I threw this one in here because listen, I'm not the best speller in the world. I'm not the best, what do I want to call it, reviewer as far as my own work, proofreading and stuff. I like to get it in, get it out, get it in, get it out, get it done, get it out, get it done, get it out. I don't like to spend a lot of time, but just look at this. Sometimes you just have to, okay? Because having this many spelling errors, grammar errors, it sometimes will be a sign of a little bit of unprofessionalism. You know, these are medical documents that could end up in a court of law someday to defend someone's services or defend someone's rights, defend something, defend the facility, defend yourself, defend the patient, defend anyone. It could happen. Things can be looked down upon. I mean, imagine if you are hiring someone, they bring in a resume and they have 23 spelling mistakes on their resume. Okay, that doesn't show you're putting a lot of effort into yourself. Put a little effort into doing this. Make sure that you proofread it at least somewhat. I mean, I'm not saying one spelling error in here is going to be a big deal, but when you have multiple ones, it's just the perception is it isn't good. Okay, so here's my validated suggestion. I didn't really write this one because I don't have to. You know it had to be fixed. But just let me give you an example here. And I actually did write a little bit there. But anyway, please clean up some spelling errors. Reviewers tend to be more critical on documentation than unnecessary grammar and spelling errors. I mean, you have to be. Okay, it can give the indication of rushing through paperwork and unprofessionalism. These are legal medical records reviewed and signed by a physician. I mean, these are important documents, guys. These aren't to be taken lightly, okay? Instead of putting difficulty with in all functional tasks, giving a percentage, a few of them would be more supportive. So here, this is what I was talking about, that objective writing. Examples: patient able to complete 50% of one little laundry before an extended break. Patient unable to complete more than 25% of the routine household chores. This helps validate the necessity, okay, and give good objective goals to make progress on. So you guys are grading this in your head. I know you are. I mean, we're therapists. That's what we do. Make sure you put down those percentages when you guys write. Be very objective in how you write. It comes across a lot clearer, comes across a lot more confident in what you're doing, and it'll really help support your claims. I'm not kidding about that. Very supportive. Okay, so there we go. There's a good example with that. All right, let's move on to the next example. Example 4. This is an OT evaluation. Okay, I know I did a lot of PT. So I had a few people actually like, oh, I thought you were an OT. All these PT ones. I don't know why. Anyway, here's an unvalidated one. Patient clinical impressions. This is on the evaluation, the assessment summary. Very important section in the assessment summary. And little side note: don't get too wrapped up on what's in what section. Listen. Put it anywhere and it's supportive. It doesn't really matter. Yes, there is something to be said about certain things should be in certain sections, but whenever you have a chance of opportunity to write very specific about what you and your therapist do, number 1, take a chance to write that. Number 2, very specific about your patients. Be able to write that too. Anywhere is supportive. So, clinical impressions. Patient presents with decreased active range of motion with bilateral shoulders, increased left shoulder pain, decreased activity tolerance and balance. Patient will benefit from OT to increase bilateral upper extremity active range of motion with shoulders, decreased pain in left shoulder, increased activity tolerance and static balance to decrease risk of falls and increase quality of life. Not the worst I've seen. Not horribly bad. I saw a left shoulder. Boom. That's a key. Whenever you use a certain left or right, upper or lower, you're getting more specific. So I like that specificness. Definitely talking about a bilateral active range of motion, activity time, all pretty good, but definitely could be improved upon a little bit here. So the reason for skilled services: patient requires skilled OT services to maximize rehab potential. I mean, come on, man. We all know that. That's what we do with everybody. Try not to put stuff like, Try not to put stuff like that. Try to always put things that are going to be more specific to your patients and kind of what they're doing. All right. So maximizing rehab potential, pretty vague, isn't it? Be specific on the deficits, be specific on the interventions, and you'll be a lot better. All right. So here's a validated example. Patient presents signs and symptoms consistent with the medical diagnosis of rotator cuff strain. Key impairments include decreased range of motion to all planes, poor strength of the scapulothoracic stabilizers, demonstrated poor scapular upward rotation with reaching and decreased motor control and timing of left shoulder musculature, resulting in pain and preventing functional tasks such as upper body and lower body ADLs and safe transferability. See? Specific deficits, even specific to the point of what muscle groups, what bones, what origin and insertion, kinesiology. Everyone hated that class. I liked it. Kinesiology, being the origin and insertion and the muscle movement and how all planes of motion are always great to put in there. The actual activity, reaching, motor control, left musculature, resulting in pain, and then how does it translate into function? Decreased functional tasks, decreased upper body ADLs, and safe transfers. See, you got the deficits, and you also got the exact functional abilities it's affecting. Skilled OT is required to address these key elements of the shoulder stability and fluctuation of scapular retraction prior to the rhythmic stabilization to promote proper joint congruity. So using those skilled words, and you guys should all have a list of these somewhere, both body, bones and muscle groups, and the ones that work in synergy patterns, all those kinds of things. Some of the origin and insertion stuff, the planes of movement. You should have a resource in your therapy area for that. Quick resource, laminated, those atlas, body atlas things, maybe some kinesiology ones, some stuff from anatomy labs, anatomy books, just that stuff to look for reference. Just get these words back in your head. So you don't lose them for a while, man. You lose them. Everyone knows that. We don't have the stuff memorized. That's what we have these things for. But getting those resources is the key. You might be able to find some of those on our app if you're interested in using that. Quick and dirty resources that we have on there for some of these things. Manually assist scapular into upper rotation to improve sequence of the GHC, talking about that shoulder muscle group, musculature, and eliminate impingement when reaching, increasing functional ability and transfers. See? Exact deficits, exact interventions. That. Now, hey, you probably were thinking the same thing. That first one didn't sound that bad. It does now. Compared to that, you didn't say anything. That's the difference, okay? Now, mine are probably extreme. I'm going all out here, man. I'm putting all those components in. If you were even at 75% of what I wrote, you're in a much better spot than the previous ones that were unvalidated. That statement to me wasn't enough to prove, especially with those patients who didn't progress like we hoped. That isn't enough to prove to me that you offered enough skilled service. I don't know what you did, and I really don't even know where you did it. Left shoulder, I got that. That's it. That's not enough. Okay. All right. Now, that was the end of section 6. Those were our quick examples. I think those are very useful. I would put more in there, but I tell you, man, those are very time consuming to kind of cover and review. I would say a good practice for you guys, take a couple of those ones home. Look up some, say, okay, I did something to the left knee. She has some upper pain in her upper hip. Look at those muscle groups. Write one with all the muscle groups intact in there, and you will feel the difference. And when you read it, you will impress yourself by doing this sometimes, okay? And then put something in place where you do that every once in a while, okay? And you'll gradually start incorporating that into your documentation. Now, remember, this is why those word builds are killing you guys. You start dropping those word builds in there, and yes, those phrases they pick are pretty good, and a lot of those phrases were from there, and we said it sounded okay, but you're missing the specifics to the claim you're discussing. You're missing the specifics to the actual person you're treating, and you're just putting it on these general statements that you're putting down for everyone, by the way. So when you have reviewers see these, and you guys pick the same stuff in the same orders, I'm telling you, man, it just doesn't look good. It just doesn't look good. It doesn't look specific enough, and it's not skilled enough, and you're going to run into problems. So be sure that you're putting more specifics. All right? Let's go to section 7. Here are some quick tips that I want you guys to remember. And again, these are things, boom, that you can just do. You don't even really have to think about them that hard. Treatment plan, frequency, and duration must be specific and reasonable to meet the patient's needs and their goals. All right? So what we were talking about earlier, specificness. You guys want specific plans, not ranges, but specifics. An evaluation requires professional skills to make clinical judgments about conditions for which services are indicated based on the objective measurements and the subjective evaluations of a patient's performance and functional abilities. All right? Objective testing is always great. Standardized tests are great. They're not great. I'm gonna say this about standardized tests though. They're not great goals for me. I don't know about writing goals with standardized tests numbers being the goal. Standardized tests are great to assess if your interventions are working towards the components to be functionally improved. But the functional improvement should be your goals, right? You can show some improvement with the testing, the standardized tests, just to make sure that you're heading in the right direction. But that should be translated over to functional ability, because that is the end all be all, right? So I'm not a big fan about goals being written just on standardized test results, but there might be a place in it once in a while. If you have a lot of goals, please don't make that your only goal. I've actually seen that. The only long-term goal was to score this number on a standardized test. I don't like that. But again, not one of these things are a reason for denial, but just things to think about. Number 3, extended care services must have been for the treatment or the condition for which the beneficiary was receiving an inpatient hospital services, including services in an emergency room, or a condition which arose while in the SNF for treatment of a condition which the beneficiary was hospitalized for. So for your short-term skilled patients, this is when we talk about the treatment medical diagnosis. Your diagnoses need to make sense, and your onset dates should make sense. If you knew when the person had a stroke, that's your onset date, not necessarily the day they were admitted. Now, are there reasons why we use the day of admission for onset dates? There are, but it's usually based on the fact that we don't know when the decline in function started, because that is supposed to be your onset date. If someone went to the hospital for a UTI, okay, I can't say a UTI would necessarily make a person unfunctional. I'm not sure when their function started to drop. I noticed it when I did my eval on the day they were admitted. Then I would say, well, okay, that makes sense. That would be the onset date, because I discovered it right now. I really saw the deficit. If someone has a stroke, is a very clear, it affects their function. If someone falls on a fall, breaks their hip, very clear what happened when or how their function, the event that I guess made this decrease in function. Very clear. That's the date you should be using. Okay? Services that can be safely and effectively furnished by a non-skilled personnel or by PTAs or OTAs without the supervision of therapists are not rehabilitative therapy services. This is right out of the benefit manual. Okay? So, what am I trying to say? Am I trying to knock down assistants? No, not at all. What I'm saying is the interventions that our assistants are using need to be at a level where a therapist was involved in implementing that into our plan, right? So what our assistants are doing are part of an overall plan developed by a therapist, and that's being overseen ultimately by a therapist. Those are therapy services, skilled therapy services. If there's just generalized, what I'm trying to get at is getting away from these generalized exercises. If they're just generalized exercises that your assistant, your housekeeper, a CNA, that anybody could do with someone, like raising a cane, doing a cone thing, yes, that's great to assess and see how someone, but we as therapists, that it should be working towards something else. That's not enough. If we're just going to do generalized exercises for people that would generally make people better, that isn't what skilled therapy is. Skilled therapy is addressing specific needs for specific deficits with specific interventions that only therapists can deliver. That's the difference. That's why we have to make sure we're getting our supervision in. That's why therapists need to make sure the interventions that are being done are appropriate and are getting results. Reports written by assistants are not complete progress notes. You better remember this one real quick, because I still see a lot of assistants writing progress notes, which they can write some pieces to that, but your therapist, your clinician, always needs to finish that note, Okay, they always need to sign it, and they should be signing it the day it's due. I'll be honest, I've come across recently a lot of notes written by assistants that weren't signed by the therapist for 2 weeks. 2 weeks. Like, I'm like, did you help write this? Well, yeah, I talked to him on the phone or blah, blah, blah. I'm like, why did it take 2 weeks to sign it? I'm like, technically, I can say that note wasn't done until you signed it, because it says right in the regulations that assistant cannot write a note, and it's not complete until the therapist completes it. And to me, it's not complete until you sign the thing. So that's 2 weeks late. I mean, I don't know about that. So again, make sure if you're going to co-sign, if you're going to have your assistants assist in writing notes, make sure your therapists that are assisting with those notes get them co-signed. I would say within 7 days. That's usually the standard we go by. It's in the regulations that a delayed note can be, is reasonable to be within those 7 days. With our caseload and time off and people not being there, make sure if they're there every day, I would get on them and say, guys, you need to sign your notes daily. That would be the best. I mean, technically, it's really not complete until it's done. So I'll make sure that those get done. All right. So on this next section, this is section 8. That was the end of section 7. Now, the reason we do these section, guys, is we put these on our training platform, and you'll be able to log in, and you can pick any one of these and just see that part. You won't have to watch the whole thing and scan through it. You can just go, okay, where were those reviewer tips? 8, okay, 8, click, 8, boom, you're watching it. Skip right over all of it. That's why we do it. But we don't break that down until put it in our training module. This is just the webinar one, so that's why I go back to back quick. But the top reviewer tips about therapy claims, okay? These are a little more intense, a little more to think about, but these are, after everything we've just went through, everything we just talked about, all the elements that are good, bad, not so good, not so bad, bringing it all together, these are the top ones I want to give you guys. Top ones I want you guys to think about when we're thinking about our claims. Not one item, and I hinted to this multiple times, not one item will get your claim denied. Okay, I'm not saying those ones that I read will be denials. Whoop, I read that. Okay, there's only a few things, technical denials, they kind of call them, when you don't have search, you don't have orders and all that stuff. That isn't the purpose of this. We're talking about documentation here and writing of it, content. We have other webinars that would cover more of the regulation things. If you guys want some of those, you can view those later. But there's really not one thing, right? It's the whole picture, the big picture. So like the scenario I said before, I have a patient that's not progressing. All the notes are co-signed by the therapist 2 weeks late. Okay, research written a week late. Right, none of the goals are updated. We're not making any progress, and we don't see one update for goals. Okay, we see a very variety of frequency week to week. We're doing 2 days here, 5 days here. Orders say 2 to 7 days. 2, 5, 3. 7. What are we doing? All those things put together. Yeah, now I'm leaning towards the denial, because all those bits and pieces, and that's why our audits have 86 trigger points we go through. The higher the number of trigger points you trigger, the more likely it could be a denial. Okay, but it's not the one item. All right. Second one, please don't cut and paste. Come on. I'm sorry. I know sometimes we write information that is redundant, but I've seen claims where a therapist would do, a PT would do an eval on the first. OT came in on the third and did it. They cut and paste. Now they're saying, they're referencing when they did their eval on the first, when they did it on the third. I'm like, well, that's weird. Now I notice that there's the exact same wording. See, now I got all these questions in my head. Okay. If you are going to cut and paste, just cut and paste a little bit at a time. Don't paste the whole paragraph. Don't cut and paste that. And by the way, they do have an option in the software vendors where you can turn that option off. I suggest you turn it off. I mean, type it out, baby. And if you're not getting enough time to do that, if your companies are pushing you to be more productive, you got to be honest and tell them, I need more time. Okay. If you want my stuff to be good, I need time to do it. And that's true. It's very true. You can't be 98% productive every day because we don't bill for documentation time, remember. Never. Direct point of care only when it's truly point of care documentation. It doesn't mean having the patient sitting next to you while you document for half hour. You don't say a word to each other. That's not it. Okay, that's not point of service documentation. That's actually billing for something you should be billing for. So I would say if you need that, you need to ask. All right. Document assistant supervision every chance you get, man. Every interaction, everything you have, a discussion, write it down. It's the best thing you can do. The more the better. Document every assistant supervision every chance you get. That's great. Be aware of patients that are not making progress. Those are the ones that are going to put you at the biggest risk. If you start to see patients not making progress, really take a good look. I'm talking to the therapist right now too, the clinicians. Really take a good look at that plan and see what you need to adjust. You want to get some adjustments in there. You want to at least show you're trying to adjust. Even if you don't think it's going to make a difference, it doesn't matter. I'm not saying you have to be 100% right about everything, but you got to document it. You got to at least show your efforts, because we will get paid for effort. But if you're not going to document it, they're not going to know. You can't say it after the fact, a year later. Oh yeah, I was going to do that, but it wouldn't have worked anyway. And that's not going to cut it. If you would have wrote it in there and tried it, and then it didn't work, you get a little more credit for that. All right. Make sure you be aware of those patients. Be very diligent on the ones that are not making the progress. Okay. General supervision requirements, initial direction, and periodic inspection of the actual activity. To be delivering general supervision of a therapist to an assistant, you must actually see that activity once in a while. Okay. It doesn't mean you can only come on weekends and sign your paperwork and then not ever see the assistant treat ever. They're there during the week and you only come on weekends. That is not general supervision. Now, in most states, it will say you have to be on site at least every 30 days. It'd be in their Practice Act. So I would use that as a general rule. I mean, if you really want to, and listen, beyond the whole idea of getting claims paid for or not claims paid for, if you want to do a good service to your residents, you therapists you have to be involved in these cases. You just have to be. Okay. You have a different level of education, and that is important, and you have a different role. I mean, the assistant's job is to do the interventions. The therapist's job is to establish and monitor the plan, and then document the results and make appropriate adjustments. If you're not doing that, you're not delivering the service. It's part of the service, man. You can't just write it once and walk away and not even have to deal with it anymore. You got to oversee it. That's what therapists do. That's what we do. All right? Do not only use word builds and checkoffs. I've literally seen, and I knew, there are word builds, drop, 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 drop. And it makes this crazy phrase that has no specificness in it and sometimes doesn't even make sense because it's all word builds. The word builds were a great idea to make sure we're putting in those trigger words that Medicare wants to see and those hot words that Medicare wants to see, but you need to back it up with more information. You need to back it up with the specifics about that claim. You can't make a word build that's specific because you don't know the specifics because they're general for everyone. You got to put more specifics in there as well, and also put what you did as a therapist. Do not document COT, CPT. Come on, man. We got to get out of this habit. I thought this was over, but I'm starting to see it again. When I look at a PT eval and it goes over the upper body range of motion and strength and they put COT, you as a PT, you need to know how strong someone's arms are to help participate in their therapy, how they're going to do. You need to know. And a PT, same thing. You need to know how they can walk. You need to know their leg strength. You need to know their balance. You can't just put CPT. This is part of your assessment, okay, when you're determining how you're going to make your plan. Don't put CPT. These things are efficient enough where you don't need to do that anymore. If it was all narratives, maybe I would say okay to that because some of these things were very lengthy along the right. They're not like that anymore. Don't do that. Fill it in yourself. If it wasn't relevant, it wouldn't be on your eval. And by the way, every claim that's reviewed is an individual claim. I mean, we'll review PT and OT, yeah, but we don't have to. It may just be OT. So I'm not going to have the PT. And if you put CPT, the auditor, now they're digging on your PT stuff too. When initially they only had to look at OT, now you have to send them the PT ones because you reference to it. Every claim is its individual claim. If you don't need items on your eval, there is no set eval form, by the way. I mean, it's not engraved in stone how you have to do it. If there's things on there you guys don't really use, just take them off. I mean, just get rid of it. If you're going to put COT or CPT every time, just get rid of that whole section. Take it out. I mean, you're not using it. And if it's not affecting your patients, fine, get rid of it. We don't like blanks. We don't like NAs all over the place. We don't like not tested. We don't like see other disciplines. Put what's relevant to your case, and that's really what everybody wants to see. And that's it. And by the way, narrative writing is the most skilled. The more you write narratively, the more you write freehand, the less builds you use, the better it will be. I guarantee it. You don't even have to think about it. Oh, I'm not a good writer. No, you don't have to be. I'm telling you, man, you don't have to be. Write it narratively, and it will be better. I promise you. Give it a chance. Document your skill first, then use the word builds. This is a hint I give to most of my clients and my therapists and my assistants. Document what you did first. Then start putting in all that other information. Pages increase this, did right leg kicks, 10 pounds, 3 sets of 10, 3 sets of 15, upper extremity extension exercises, TheraBand exercise. It's fine to write all that. After what you did there, that you facilitated weight shift, you facilitated muscle memory, you facilitated dressing tasks, you initiated this. Put what you did first as your therapy team and your skills, then write everything else. You know why? Because if you start writing everything else, you're going to forget to do that, and you're just going to be rushing to get it done, and it's going to look good enough because it's going to be all filled in. Put what you did first. You want credit. You're looking to prove your skill as therapists first, then your patient's abilities after and how they improved. But they want to know what you did. Write specifics on your patient's deficits and your skills, just like we talked about earlier. Specifics, okay? Not only left arm, right arm, what muscle groups? What does it look like? Is it bruised? I mean, is it, are you talking about dull pain, sharp pain? Get very specific. Don't just say inability to use arm secondary to pain. Well, what kind of pain? And when does the pain happen? And how do they describe it? How do you know it's not psychosomatic? How do you know it's not something that's in their head? How do you know it's even not referred pain from another? Be specific about all those things. Don't just put there's pain. I mean, everybody has a little bit of pain. I'm in pain right now. You know, you're getting older. I mean, you get pain when you sit too long. You go to stand up. But is it relevant? And is it important? Is it affecting their abilities? I don't know. That's why you got to write a little more. If you're going to use pain management, if you're working on pain, you better be specific about pain. And by the way, pain's on the MDS now, and if it affected a person's ability to participate in therapy, that's going to be on the MDS coming October. We're back on that. So being specific is going to cover all those. You wouldn't even have to worry about that, right? If you were being specific about everything you did, you don't have to worry about some of these changes coming up because you're going to have it down. Be specific about your residents and about your skill. Specific, the more specific, the better. All right. Well, there we go, guys. Got it stuck down about an hour and a half, just like I was anticipating. I thank you for your attention. I know I went through it fast, but you can always watch this again. And then if you are interested in some more of our services and some more of our overall trainings and our training platform, you can go to either our website or our app, and you guys can check that out and that opportunity. There are charges for some. There's a yearly thing you can get into and you get them all, but I do deliver a lot of them free, but I put them in this training site just so it, this isn't a money maker, trust me. It's just something I can pay the guy who does it for me to do it, essentially is what it comes down to. So section them all out so you can use it as a really, really quick reference tool. You can go to any one of those sections at any time and double check them. It's really cool. If you do have any questions or concerns, you can always call our office. It's 1-801-PDPMpro. We have picked up some business. We have some new things coming around the corner here. We have October coming, so we're doing a lot of MDS training for Section GG, things like that. So if we don't get back to you like super, super fast, apologize, but we have people working on this stuff for us. info@jmdhealthcare.com. You can shoot an email to our office. A lot of those do get forwarded to me, by the way. I'm still the main one that likes to answer some of those questions. So just make sure you put in the subject line the electronic documentation success. That helps us to sometimes know what your concerns are, what you're asking about when I see the question. Sometimes you don't put all the information in there. If I know it's about the documentation success training, I can kind of fill in some of the pieces. But if it's about MDS training, I'm like, okay, well, what's this about? So, or there's our website, PDPMpro.com. If you have any questions with that, here is our app. You guys can download the, I'm sure you already did, a lot of you, the slide deck You can scan these QRs, get our app. It's got some good resources on there. That's usually what it's for. Have some free trainings on there. It has some of the handouts on there. Great MDS and therapy stuff, both. We deliver a service that helps oversee both of those for you guys. So good stuff there, available to you whenever you need it. All right, and that's it. I hope you guys enjoyed this. If you have any other questions, feel free to reach out. We'll have another great informative webinar for you guys very, very soon. We'd love to hear from you guys. If you ever need any questions, have any concerns, or need any services, feel free to contact us. We love doing it and we enjoy it. So that's about it. And hopefully everyone has a great week, and we'll see you soon. Take care.